Good afternoon, everyone, and welcome to today's webinar, which is part of the University of Maryland Medical System's Let's Talk About Health series. Glad to have you all here today. As Peter said, I'm Donna Jacobs. I will moderate today's program. As I say often, the Let's Talk About Health series is designed to do a few things: to increase awareness about important health topics, to provide tools to bring about better health, and to improve health-related conversations between patients and community and medical providers, and important for today as well, discussions amongst families. April is Autism Awareness Month, and thus our topic today is all about autism. Leading today's conversation will be Dr. Harper Johnston. Dr. Johnston is a PhD child psychologist with 30 years of experience in the field. She leads the Autism Spectrum Center at Mount Washington Pediatric Hospital, a children's specialty hospital in North Baltimore. Under Dr. Johnston's leadership, the Autism Spectrum Center prioritizes patient self-advocacy in treatment and adheres to the philosophy for patients that there should be nothing about us without us. I love that expression. Dr. Johnston strongly believes in teaching patients and families about the importance of self-advocacy and creating learning opportunities to ensure the most effective patient outcomes through the use of video, accessible therapy curricula, and other means. Before I turn this over to Dr. Johnston, let me just remind you of a few things for our frequent listeners and perhaps for those who are new to this series. As we proceed, remember that this is intended to be interactive conversation, and albeit we are virtual, we can still have a two-way dialogue. And as Peter said, therefore, please type your questions that you may have at any point in the Q&A box, and Dr. Johnston will be happy to answer as many of those questions as we have time for. Please do make your questions general. We're not able to do specific diagnoses along this conversation, but please ask questions that are of general import and importance to our audience, and she'll be happy to address them. This conversation, again, as Peter said, is being recorded, and both the slides and video will be available to you in a few days. I'll give you that information later toward the end. As we get started, next slide, let me explain for some that we do cast these webinar sessions in a context in a way that can help patients and families really remember communication and remember the information that they're given. And we use the model that you see here. It's called Ask Me 3. It really is a way to make sure you get your questions answered and remember the important information that you're provided. So Ask Me 3 is really just 3 easy questions. If you describe a scenario or circumstance that you're dealing with, then you want to follow up with 3 questions. What is my main problem? What do I need to do about it? And then why is it important for me to do this? What's the purpose of me taking the action that's been recommended? These we find are really helpful to patients and families when sometimes medical conversations can be quite difficult. As we proceed, Dr. Johnston will give you several examples of Ask Me 3 scenarios. And with that, Dr. Johnston, I think I'm ready to turn this over to you and say thank you in advance.
Thank you so much, Donna, for the opportunity and the forum to speak on behalf of the autism community. Going from these very important questions, from the approach as a developmental psychologist, I'm going to define the main problem as symptoms of autism and, more broadly speaking, related disorders that involve communication impairments or deficits, differences. They limit the treatment options and participation. So it makes it more difficult for children to participate in the same variety of supports that are available for the neurotypical community. The solution to that is to encourage everyone, and that's from providers, parents, children, self-advocates, to ask for adaptive communication supports. And the reason for this is that effective treatment starts with patient rights. And unless the patient is actively involved, their rights aren't being protected. So starting with the first problem, the symptoms limit treatment options and participation, we're going to unpack that a little bit so that we're mostly on the same page and talk about, first of all, can you see this? The title slide,
What defines the autism spectrum?
right.
Yes.
So my control panel is not occluding it for the viewers.
Dr. Jones, no. So
No.
that's only
Okay.
on the
All right.
group.
Wonderful. Thank you. I just needed to clarify. Sorry about that. Okay. So what defines the autism spectrum? There's a couple of ways of looking at it. People may refer to high functioning or low functioning. But what does that mean? Some doctor says, okay, well, you can do this, and this other kid can do other things, including reading or getting a diploma versus a certificate. Who really makes those decisions? And there's a lot of variability in performance with autism. So maybe we could look at support needs. How much support do you need? High support needs would be the same as saying low functioning. And high functioning might need fewer support needs. So high support needs might be more complicated and need more types of therapies and more involvement and IEPs. And low support needs might be able to get most of their resources in the community outpatient programs. So here is the issue. When we're talking about high support needs, people usually look at behavior therapy and therapies that are done to the child with less direct involvement and choice, as opposed to cognitive behavior therapy, which relies very heavily on the patient to do self-reporting and make a lot of active decisions. So how do we bridge this gap between services? And we're going to back up and zoom out and say, well, how do you treat differences in intelligence? And to answer that, we say, well, what is intelligence? We think we know what it is, but let's basically define it as being able to attend to information, like here's a basketball game, memorize the right information and sort and organize that information, and then use that information adaptively. So that would be one definition of intelligence. But how is intelligence different in autism? So 30 years ago when I started, well, 1994, I was working in a group home and I was teaching these two kids to play electronic basketball. And there was a kid that had an intellectual disability, but he was very, very verbal speaking. And he was very interested in the game and he kept trying. And then there was the child with autism, who we'll call Austin. These are not the real names. And Austin just wouldn't even hold the ball. Every time I gave the ball to him, he would drop it. He just wasn't interested, it seemed. And I thought because Austin was non-speaking, he was mute, that was because he didn't understand. And I thought that he was more intellectually disabled because he couldn't speak. So here we are. We got 2 minutes left of the game. It's 5-0. Austin hasn't had a single shot. And so I, being 19 and very idealistic, gave a really great enthusiastic speech telling him, all you have to do, you could do this, you only got 5 points, you could do that in 2 minutes, and you can win it. And Austin takes the ball. He doesn't drop it. He takes the ball. I think, yes, I'm making a difference. And then I hear this sound. He took the ball to the back of the machine. I see the panel in the back of the machine where the electronics are there. It's open. And I think, oh no, he broke it. And this kid breaks things all the time. And this is just a failure. And then I look at the scoreboard because he goes like this. And I see the scoreboard. And what happened? He won the game, which was basically he dropped the ball and it gave me a direct look with eye contact, which he never did. Like, that's the way you win the game, lady. I don't know why you were trying it the hard way, putting the ball in the basket. That's how you win. And that was basically his version of a mic drop. Like, that's how you do things. And that really stuck with me, and it made me think for a long time. So let's talk about autistic intelligence. Maybe they're not paying as much attention to social information, so less social attention, but they're paying attention to something. So they have a different default focus, which means they're memorizing different information, which means that they're using the information differently than social expectations. And that's where invention comes from. So let's take a look at what the numbers say. This is my only data slide for you. Here we have data, meta-analysis on, in the gray areas, you'll see people who are considered neurotypical without a diagnosis. Orange is related disorders or other diagnoses like ADHD. And blue is autism. And what you see that's different in the autistic population is what the people who like statistics call a bimodal distribution, which is not a bell curve. It's not predictive. It is all over the place. You have some people that would be considered low intelligence, some that are high intelligence. And the other issue is that the intelligence doesn't correlate neatly with functioning or success in all sorts of metrics. So what that means is we're not testing what we think we're testing. And so it's really difficult to measure intelligence in autism. It's like the standard test. The performance varies based on the tester. So here you have, for a fair selection, everybody has to take the same exam. Please climb that tree. And I like showing this to some of the kids who I work with because it really resonates with them that they're not being tested. People constantly underestimate their ability. So if there's any providers here, presume competence. That's the number one golden rule when you're working. Talk to the kid, the same that you would with another kid who's not non-speaking. All right, so let's talk about this from a strategic approach as a therapist or as a person who is a consumer of therapy. What is the right treatment for my symptoms? So a standard treatment plan, from my perspective, is to minimize the disabling aspects of autism so that the strengths of autism can fully develop. There's a lot packed in that sentence, but part of that is disabling aspects, disabling symptoms. So those are the things that get in the way. So first, to understand that, we're going to look at, in general, what things do we need as human beings? And we're going to look at the evolution of needs, starting with safety. Our number one priority is safety, and once we know that we're safe, we're free to move on to the next priority, which is resources, food, and comfort, and safety. Tools and work. Once we are safe, we want to be able to use things and do things, and then we want to learn and be independent, and then we want to network. This is as humans, this is the priority of needs. So in therapy, treatment goals would be at the basics, knowing how to self-soothe, knowing how to calm yourself down, stop a panic attack, how to communicate effectively, how to follow rules, how to be independent, and how to be socially successful. So broadly speaking, the first half is behavior therapy, and the second half is cognitive behavior therapy. So who has the symptoms and the problems? Who's the patient here? Who needs the skills and the supports? Well, starting off with basic skills, behavior therapy, which can be ABA. ABA is home-based. It's run by technicians and behavior analysts in the homes or in centers, not in hospitals, but behavior therapy is done in hospitals, just for clarification. Verbal behavior therapy, which is a specific type of ABA for kids who have specific communication challenges, is something, again, centers. You could get some verbal behavior therapy techniques used in psychotherapy, but typically speaking, verbal behavior therapy is done by behavior analysts, ABA workers. Parent-child interaction therapy, PCIT. There's a lot of versions of this, but at the Autism Spectrum Center at Mount Washington, we have many clinicians who can use this type of approach. More clinicians who can do family therapy. This is the type of thing that's not specific to autism. This is the type of general family psychotherapy that you would do. And then cognitive behavior therapy. We have a lot of therapists that can do CBT with individuals with a variety of differences. Because cognitive behavior therapy, it doesn't require as many modifications because it's talk-based therapy. So let's look at these. The structure of my talk is we'll go through all 5 really quickly, and we will give one example for each. So for ABA, parents might report the following symptoms as being disabling. The child can't follow basic directions, won't even sit down, won't do anything. Tantrums a lot. They need a one-to-one for safety. I'm constantly having to be on top of my child to keep them okay. And they can't stay in school or therapy. We tried preschool, we tried therapy, they get kicked out. The behaviors, they just don't do anything. So this is like a starting spot for kids who are struggling. And in applied behavior analysis or behavior therapy, the data is based on observable behaviors only. That's really important because we don't really talk about the kid's perspective so much in it. The therapists or the ABA therapists will analyze the function of the behavior and figure out why the kid is doing it. And then they will work directly with the child to do troubleshooting and try to figure out what's going on. And then based on these probe data, they will create a behavior intervention plan. And then they might use motivation systems like token boards to try to improve outcomes. Verbal behavior therapy is different because this is more communication-based. So the child can't answer questions. They tantrum to get their way. In other words, that's how they're communicating. And they don't get along with peers because they're not communicating with peers. So verbal behavior therapy is very structured. It can be done in home or center-based. You usually have a one-on-one. And they follow a verbal behavior curriculum that breaks down complex skills like communication into basic units like making eye contact and oral motor imitation and very, very specific teachable units. And then they provide prompts, which they call errorless learning. So we're going to support your learning. We're going to prompt you until you can do it on your own. And then they do this through discrete trial teaching, which is here with one-on-one support. And they take daily data so that they can change treatment every single day so that they're not missing anything. And that's a good thing. It can be a bad thing, but it's a good thing to be able to take daily data because you really sort of capture the differences between what is missing at this lower level and what is mastered at this higher level, which is part of the variability in intelligence that you see. Parent-child interaction. Kids that are misbehaving for attention, this is in quotes because from the kid's perspective, they wouldn't say it that way. Attention is a currency we all use in exchange to get something else, like help or reassurance. They might be described as oppositional and defiant. Again, not their words, the parents' words or the teacher's words. And they may be tantruming more at home, and that's why they're getting family therapy because they're not having the same problems at school. So in parent-child interaction therapy, what you have is child-directed at first to build the attachment between the parent and the child, and then it shifts to parent-directed, which is behavior management, setting limits, through teaching and coaching lessons, which can happen in the clinic or virtually. So you sort of have a headset bug in the ear to the parent, and you're watching them in the home doing something that can be very effective for those home-based behavior issues. And then there's a lot of reciprocal games that teach people how to tune into their kid and read their signals. And there's a lot of qualitative data that goes through this. So it's not the same as the quantitative data. We're really looking for the experience that you're reporting and how you feel like therapy is going. All right, family therapy. Family therapy is when the issues expands beyond the child, so we can't discipline our child. We're always stressed at home. Family conflict is getting worse. This is a we problem. And in family psychotherapy, the parents and the children report barriers, often both talking from different perspectives about what's going on. And so we use the both and approach where they're both right and they are both wrong. And we're not going to judge anybody. Maybe you're 1% wrong and the other person's 99% wrong, but we're just going to use both ands because that is the only space that makes it possible for the healing and the treatment to be effective. And there's a lot of family psychoeducation on symptoms management, and even self-advocacy to help treat kids. And the particular treatment that I teach people at our hospital is based on Ross Greene's collaborative and proactive solutions for challenging behavior. Basically, collaborative, proactive contracts. A lot of contracts where we agree, well, this is my perspective, this is your perspective, and we try to get the family together. Cognitive behavior therapy, which is the psychotherapy we usually think of when we're thinking of psychologists. This is from the kid's perspective, or the parents might say this about their child. I can't break my bad habits. I just want to feel normal, and no one understands me. So these are common reasons why people might come for CBT. And CBT is really looking at that beliefs, behaviors, and feelings dynamic relationship. Patients report their feelings, and this is the key. They get to report their feelings and beliefs and behaviors. And if they aren't able to do that, they can't participate in CBT. So there's this bottleneck of kids who really need CBT who can't do it because they're not speaking yet. Data is based on facts reported from other places, but also the child's beliefs about what's going on. And then we talk about the cycles in CBT between the feelings, beliefs, and behaviors, and we learn functional alternative habits. And there's a lot of do-it-yourself data. Some of it might be from the school, the teachers, other people, but a lot of it is based on patient report. So what if we can't participate in the right treatment? This is a huge problem because kids, especially after the during and after the pandemic, there are a lot of kids who have trauma, and even educational trauma from when they were restrained in schools, for example, or issues that, divorce, death, anything that happens to a kid. If you're not speaking, you can't access those therapies. So what happens? We have to make the therapy accessible. So here's where I'm going to spend 10, maybe 5 minutes talking about adaptive supports. Really quick overview, how we can support accessibility. One example for each. In ABA, the big accessibility problem is that kids are sort of forced into it. So what we want to do is we want to get their consent. We want to get them to be interested. We want them to want therapy. So we use their curiosity. So if a kid loves spinning, then we're going to start with a spinnable puzzle and we're going to teach them those skills. So we're going to sit at the table, and when you're sitting at the table, you can spin these things. I'm going to show you a really cool way to do it. And then we have to put together this thing as we're doing it. Once we do that, we have the experience of completing something. And once you experience completing something, when you've never really completed anything before, that really is addictive. You're like, wow, maybe I am competent. And then we expand on that. And then the kid wants to do therapy. No candy involved. They check it off their list, and we find more things that they're interested in doing that they want to do. And they complete the tasks, and then we build on those. And we build focus skills until finally they can do a series of things, and they're ready to participate in speech therapy or whatever therapy they couldn't do before. Verbal behavior therapy, which is ABA with communication training. We're going to add to this before the kids are able to communicate manipulatives, things that they can hold and use, that they can control. So an example of this, a common problem, one of the stages that we all share in language development is echolalia, but with neurotypical people, that stage is short and it lasts a very short time. But for autistic people, they process things slowly. So when they're processing things and you ask them a question like, what do you want to do? Or what is your name? They might repeat it back to you. What is your name? What do you want to do? As they're processing it, right? So we give them the steps. Okay, first you need to look at the speaker. It doesn't need to be direct eye contact, but you need to be generally aware of the person that's talking to you. And then you give them the next instruction. You need to listen to the question. Did you hear my question? What do you want to do? And then I give them a cue. Now, this is my favorite. I have this Super Mario Brothers question light, and when you hit it, it lights up and it goes bling. And the kids use it like a game show buzzer. When they're ready to answer the question, they hit it again, bling, and it goes off. But the question mark stays lit until they answer the question, which effectively lets them know a question has been asked. Take your time. And this gives them the space to think. And then as they're thinking, instead of me saying, come on, what's your name? Or what do you want to do? And I keep repeating questions. If you do that, it has the same effect as clicking the mouse too many times on a program that is processing something. It will freeze. Kids freeze. And that's a lot of kids who don't speak functionally or are disfluent is part of this is because they get prompted too much when they're in this stage of trying to find the word that they're looking for. So then we give the visual prompts, we stay quiet, and we give them another signal, which is how to ask for help if they need it. And then we practice. So we're using a lot of prompts, and that is helping them transition. Okay, I'm aware of the time, so I'm going to go quickly. Parent-child interaction therapy. We want to use visual prompts so kids can follow along. So whatever I'm telling parents, like this is how we do active listening. We mirror, we validate. Oh, I get it. You're so mad you'd rather play Fortnite than do your homework. I get it. And then you pause because remember echolalia, it takes some time to process. And then we wait and we see if the kid stays upset. We give them one cue, we redirect them. Well, here are your choices. If the kid calms down, we offer connection. Like, hey, we could do this later. And everything I'm telling the parent, I'm also using visual prompts and showing the kid so that they can follow along, almost like a consent, like, oh yeah, that works for me, or object if that doesn't work for them. So that's how we keep the kids involved for that. In family therapy, it's very similar, except the kid has some responsibility and so does the parent. So we have visually prompted worksheets for family practice, but it looks like this. Oh, we're going to talk about assertive communication versus passive-aggressive or passive. And we're going to practice this. We're going to practice it together in the session. And then you get to pull this out and talk about it at home and give examples of when you think that your parent has been passive-aggressive or aggressive. And then the parent gets to do the same thing. But it really makes both parties accountable for the communication in the space between them. Accessibility in cognitive behavior therapy is my favorite topic, and I could give you 5 hours worth of TED Talk on that because I've been developing a program to make visual prompts in special education type of form of cognitive behavior therapy. Essentially, it boils down to graphic organizers and ways to teach self-reporting. So here's an example of talking about your school day. Kids can follow along picture schedule, even if they're not speaking, but they may not be able to tell you about your day. Even kids who are speaking, who don't have autism, you say, hey, what did you do in school today? You're going to get, it was great. Nothing much. You're not going to get many answers. So to get that richness of detail, we go class by class and we talk about the feelings. And we might start with a binary, which would be like a sorting task. But eventually we get kids that can really tell us where they're having the hardest problems. So in here, lunch is really low. A lot of people like lunch. Why is lunch low? And then we talk about their attention. Like, oh, we all say pay attention. Well, let's say in my office, we have attention dollars, and you have $100 of attention you wake up with every single morning, and you can use it and spend it whatever way you want. And sometimes kids come into my office, and they're tantruming or they're having a hard time, and I say, wow, how many dollars of attention do you have? And we'll use fake attention dollars, and they'll tell me that they really only have $10 left for the day. So we can't really push them the same way. From the attention dollars, I've found out that a lot of kids pay a lot of attention at lunch. I mean, lunch is expensive for them. And that's where we start to say, oh, sensory processing problems. It's busy, it's crowded, there's a lot of smells. And then we can understand what's going on with their day. And then we can also do sorting tasks where we talk about these higher order concepts, like what can you control on the inside and outside? What's easy? What's hard? Using picture cards and sorting tasks. You get a lot of information from that. So patient rights. I just want to confirm, Donna, that I have 7 minutes to go through patient rights.
Sure.
Sure. Okay. Thank you. Sorry. I have a lot to say. So looking at patient rights, we start with consent. That's always the first right. The right to make choices, to collaborate for collaborative care, to negotiate what goals you want to work on, and to advocate for yourself. So starting here, the right to consent. When you go to the dentist, we have this universal experience of being a non-verbal, non-speaking patient, because when they have their hands in your mouth, you can't communicate. So when you're there, you might experience anxiety if your dentist doesn't tell you what they're doing, where they're drilling, or what the procedures are. But if they go through everything with you, then you feel okay, like this kid in the bottom here. Let's talk about desensitization. Kids who have behavior problems, a lot of them might have a startle reflex or panic or get very aggressive because sounds are too loud or something. And if we do desensitization programs, like a lot of places do, where they'll play loud music or loud sounds increasing amount of times, and then they'll reward the kid for tolerating it with some gummy bears. The problem is that doesn't solve the problem. That does not treat the problem. The kids are terrified. The same as goes for other types of things like feeding therapy can be this way. So does candy make you feel safe? What amount of gummy bears do you need to stop a panic attack? A bunch? All the gummy bears? If I were to threaten to hurt someone you love, how many gummy bears would it take for you to be okay with that fear feeling? So from the kid's perspective, they're very scared, and gummy bears isn't solving the problem. So let's talk about informed consent here. Kids have the right to choose if they want to enter into a specific counselor-patient relationship, and to choose what they do or don't want to experience in treatment, and to start, stop, pause, or change treatment. So let's imagine that we need a safety signal because we're panicking, because we're late for something. What signals do we need when we're panicking? I'm stuck in traffic. I want to know what's happening. Am I safe? What's the cause of this? Can I avoid it or escape? Is there an alternate route? How long will it go on for? And what are my coping choices if I can't do anything about it? Like, ooh, there's some coffee shops and bars in the neighborhood. So kids want the same things. So if we do desensitization in a different way, and we start to talk to them about the time, not the gummy bears, but the time and the negotiation part, we say, okay, let's do this uncomfortable thing for 3 minutes. And every time that you stop, we're going to pause the timer. So it could only take 3 minutes, or it could take the whole session. It's up to you. But you can stop it at any time. You have the control. You get a lot more traction with that, and you get consent. Also, any therapist, any doctor should always get consent for treatment with their kids whenever possible, or model giving consent. I use my ID badge anytime we go into therapy, and if the kid doesn't want to use the ID badge to go from the waiting room into my office, then we stay in the waiting room until either the child explains why, or maybe we cancel the session. Because if that was a speaking patient that said, hey, I'd like to cancel the session, we would allow that. And then allow them to stop during the session at any point. And I have a service bell, which kids love to use. And they use it, and then it gives them a choice menu. And I use picture cards, and we negotiate that. So they have consent to continue. So right to choices. That brings us to, what are the choices then? One therapy goal used to be, and still is in a lot of places, establishing instructional control, making sure the kid will follow directions. You must look at me, eye-to-eye contact. You must keep your hands down. This is very strict, and it can be aversive to kids with autism. So giving them gummy bears to do these things is not setting up therapy in the future for success. It's not even ethical, really, in psychotherapy. So back to our gummy bear problem. Kids have the right, all patients have the right, to understand treatment options so that they're explained in a way that they can understand. Getting back to our picture cards and props, sometimes we need to use that to get that. and to be able to effectively participate in care and decision making at the level that they choose. In my office, examples would be picture stories about what the expectations are, what we're going to be doing, and a way for them to ask questions and get clarification. Also, treatment choices. What do you want? My office is littered with magnetic communication cards and boxes that are labeled with these cards. So kids can ask for things at any point. They don't want to do this skill this way, we'll do it with a different way. They have a new choice. Also, they have a way of communicating when something is going wrong and they're starting to panic. A lot of kids with autism have correlated gastrointestinal issues. So there might be something going on that we can't see, and they need to pause at that moment. And it's important that they have the ability to make that request. Also, we have a lot of different things we can do to reach those goals. So giving them picture cards and letting them set the schedule. We usually have a 3 or a 5 set schedule, and the kids get to choose what they're going to do in therapy. And so let's go back to social skills we teach in therapy. Candy is not a social reward. When I started in the field, I was doing my dissertation and I was working with kids, and we had these tackle boxes in the 90s where you would give kids a reward for eye contact or whatever you're asking them to do, and they get to choose the candy. And I had this great idea. I'm going to use my Pez dispensers because I am at heart a geek about certain toys. And I had this great collection of Pez dispensers, so I started to dispense treats out of the Pez dispensers, and the kids loved it. Lots of rewards, lots of motivation, but they weren't eating the Pez. Why? Because I was the crazy Pez dispenser lady, and they liked to spend time with me and play. And then that led me to believe, oh, that little geek culture thing kind of resonated, and then it became truly social because we were sharing something. Social goals should have social rewards. And there's a huge geek culture around Pez dispensers, but it doesn't need to be necessarily that. It's just finding something that you can engage with the child in that's not just giving them candy. The right to collaborate. A lot of behavior plans are written from the kid's perspective as if they are, always disruptive and these are their problems. So we say, oh, the kid's cranky, they test limits, they're defiant, they're violent, they get out of control at the highest point. This is a bell curve indicating the rise and escalation of a tantrum. And so we say, okay, parents, now you have to, at this level, you got to be a therapist. Here, oh, the kid's starting to escalate, so you can only really be a teacher. Here, you got to leave the room and give them 2 choices. Here, you should be a security officer and start clearing the area, especially if you're a teacher. You got to make sure that you're modeling the behavior. And then when you get to this highest point, when the kid is in the red zone and they're really panicking, you got to stay behind the child and be a couch or a chair so that you can support them but not get hit. And so we talk about that. And this is very important, but it's only from the kid as the primary target of the anxiety. In collaborative care, we include both patient and family perspectives for skills, barriers, goals, experiences, and cultures into healthcare planning and delivery. So that means we're responsible to do it from the kid's perspective too. So the parents are also having an emotional moment, and their feelings as the crisis escalates go from, oh, somebody's cranky. What was that plan again? Why are they doing this to me? Oh no, everybody's staring. I can't handle this anymore. Panic. This is an escalation that the kids read and they know about. They see. So I did this activity when my kid was young and struggling, and he told me that I do the following things. I might have a sarcastic tone or roll my eyes. I might be condescending or use a Disney sing-song voice. He says it's the therapy voice. Or I might give the look. Or I might start threatening. Well, that's it. No computer for a week. Or the worst I've ever done is once I restrained my son because he bit someone. So those are the things that I did that I would do differently, that I didn't realize he was picking up on. And it's important that we are accountable as caregivers and that we get that information from the kids. So also kids have the right to negotiate. So in true family therapy, there's all these interesting strategies for behavior that involve shame. This has no place. We should not be shaming kids. Like here, shaming kids in a group in school. Oh, this kid had better behavior than the other. For a neurological condition, it's not right. And then shaming them at home to say you're good or bad, also not right. Shaming symptoms is not part of treatment. You're flapping your hands because it's a valid way of you expressing yourself. Telling you to put your hands down and then punishing you for it and shaming you is not a way to get you to feel good about yourself. And it is part of the problem for why there are high rates of suicide and depression in autistic adults. So to prevent that, patients need to negotiate autonomy and be treated with dignity and respect under all circumstances, even if they're on the floor of your office, kicking and taking things off of your office. Also, to receive accurate information. So we say, you just had a panic attack. It feels like this. Here's a metronome. Let's talk about fast and slow heart rates to help them really unpack it afterwards. And then when we do come up with our behavior intervention plan, for example, my kid doesn't do this. He doesn't clean his room. He doesn't do whatever it is. We're taking it, here are the barrier behaviors, and here are the cues that they need. So we're putting the responsibility square in the middle of the child and the parent. And if you're not both prompting and practicing, then it's everybody's bad habit. Little controversial and not an easy pill to swallow as a parent or as a parent of a kid that had IEP and other things, but it is the way to get effective treatment long term. Okay, right to advocate. Therapy treatments that are aimed at masking symptoms like quiet hands, quiet feet. Patients need to feel normal, not look normal. Okay. Self-advocacy is patients managing their symptoms by developing adaptive skills themselves or explaining what they need so that they can actively access this with other people in the community. And a lot of patients really look at the story of Rudolph the Red-Nosed Reindeer as a self-advocacy story, because here Rudolph, if you're familiar with the original TV animated movie, when he was born with a red nose, they plug it up with some muddy muck over his nose, and he has to wear this mask the whole time. A lot of kids resonate with this, and they say, I am tired of social masking. When I get this reaction, is that my symptom? If my peers laugh and call me names, I don't want to play their reindeer games. So you got a lot of, yeah, you didn't lock me out. I'm locking you out. I don't want to be part of your group. So that questions, how are we teaching our social goals? We need to really look at social goals that are harnessing the light, where we have authentic friendships and we are sharing the strength. So to support advocacy and self-advocacy, we want also active, anybody that loves this kid or is part of this kid's community can help with helping that child and supporting patient groups that bring attention to these issues, like what we're doing today. So all of you are advocates by participating in this. To look for systemic change. So all of you that are here today, I would like you to ask your providers for communication supports the next time you see them. And it's also imperative that therapists start talking about ableism and the trauma of ableism and the words that people have used to describe autism, or, oh, your kid's autistic. Oh, when somebody tells me that their kid is autistic, I say, oh, some of my favorite people in the world have autism, because it is also a strength. And it's important that kids see that. Otherwise, they cannot overcome the disabling aspects of autism that are optional, which is the depression and anxiety. They don't have to grow up to feel suicidal thoughts if we support them. And that means the whole clinic needs to support them, which means wherever you go should be signaling neurodiversity as a theme, the same way that we signal it for multiculturalism. So people know that they can be accepted if they can't speak and they have other interests. So this is a coloring page we use in our program. We have it in our waiting rooms. Last thing to say is about motivation. I know I don't have a lot of time to talk about this, but we all say that motivation sort of goes down over time. And the reason for that is because when we start with motivation out of obligation or rewards, and it's there, it's external, but over time it loses effectiveness. The only things that we stay motivated for are things that are internally meaningful to us. So how do we do that in therapy? Most people stop goals. It's not that I'm lazy, it's just I don't care, right? Well, how do we make patients care and commit? So the motivation game, what are the top things for motivation? And they are mastery, mastering a skill. It could be as simple as flipping a bottle over and over again, which kids like to do, or Rubik's Cubes or whatever it is, but mastery. Autonomy, doing things on their own. You have a kid that just wants to buckle their own seatbelt. And maybe that's important, so you got to spend 20 minutes doing that with them. Sense of purpose. What are you bringing to the table? Are you connecting with other autistic self-advocates? Is your life meaningful? Happiness isn't an achievable life goal, but fulfillment is. And then the last one is robot car simulators. I had mastery, autonomy, and purpose in my office with these little magnetic letters. And as I was explaining this to a parent, I had a kid who was non-speaking and also illiterate, who came in and wrote robot car simulators out of the magnets, and I realized that he wasn't illiterate and he had a lot to say, and so we started typing after that. And I still don't know what robot car simulators are, but it's part of that geek culture. It's that curiosity. So we ask, what do you want to get good at? What do you want to do on your own? Who do you want to help? And what are your special interests? So in summary, the problem is symptoms limit treatment options. And the solution is to ask for adaptive communication supports, because effective treatment starts with patient rights. And the rights are consent, choices, collaborative care, the right to negotiate what you want to do, and the right to advocate. Here is a long list of advocacy resources if anybody wants to screenshot these for self-advocacy, and they can be available afterwards. And with that, it is our 100-year anniversary at Mount Washington Pediatric Hospital. So here I'm having a little birthday party with Cookie Monster and one of my patients. Thank you so much for giving me the option to talk about this.
Thank you so much for doing so. We certainly appreciate it. We'll take questions in a moment, and we'll have some answers for you. One of the things that Dr. Johnston and I spoke about is many of you in the audience likely have other self-advocacy resources that you are familiar with that you might like to share with the group. If so, go ahead and do that. Put that in the Q&A. We will preserve it. And several people asked during her talk about information, or whether you could get the slides. The slides and the presentation, the video, will be available to you in a few days, and I'll come back to that right at the end. So if you have resources that you'd like to share with others, please do. Dr. Johnston, can I take you way back? Because I was thinking as you were speaking that we probably have a wide array of listeners here. I'm sure we have parents who are well-versed and are aware of the autism challenges, rewards, etc., and have been dealing with it for some time. But there may be some out there who are not sure what they're dealing with. So could I ask you to define autism and speak to what the spectrum is and what parents might need to look for?
Absolutely. Before I do that, is it okay for me to go? Would you like me to keep it on this slide?
Oh, sure. People can watch.
Okay,
sure.
All right. So the autism spectrum, the definition of autism has changed a lot now that we have entire generation of kids who grew up with early intervention and are able to very, very vocally and verbally, so those that speak versus those that type, tell us what we got wrong. And so I am always updating the information. I myself am not autistic. I'm neurodivergent, but I'm not autistic. So I don't know exactly what that's like to be autistic, but from my experience, the core areas that are different are a focus on more scientific, object-based, like physics-style interests when you're a young child, when other kids are interested in that interpersonal dynamic and peekaboo games and touch and things like that. These kids are looking at ramps and the way things move, and they're much more mechanically oriented. So you could call it a symptom, or you could call it a different way of viewing the world, but they're not really looking at those skills. So from a developmental perspective, it's a deficit in reciprocity, which is that back and forthness that we have. Like, I'm going to adjust what I say and do based on your response. And that keeps going. So that is one of the core deficits. Difficulties with imitation is a core deficit because there's some research on mirror neurons and the ability to sort of see what is going on with someone else and replicate it in your head that might be impaired. Differences in how we look at faces, which prevents us from making eye contact the same way. An autistic might make eye contact peripherally or might need to do things to reduce the sensory information because literally they're getting too much information. And when we make eye contact differently, eye contact is the basis of determining people's intentions. So if you're not reading eye contact the same way, you don't know a person's intentions or what they're going to do next as a baby. And then all those skills that come after that are difficult for you to understand. So you're never sure if you're safe socially. So eye contact, imitation, reciprocity, and then those things affect later skills like communication, social skills, and the ability to know when you're safe, because we rely on social signals to determine if we're safe. For example, if you were in my office and the fire alarm went off, the first thing everybody does is they peek out and they look to see, are people running and screaming? Or are people walking slowly? And that's how we determine what level of anxiety and concern we should have. And for autistic kids, because they're not reading that information, they are often upset for no reason because they can't reassure themselves.
Very helpful. Very helpful, very important, informative. So we have some questions coming in now. What kind, I think this is excellent, what kind of adaptive communication supports, this is so appropriate to our context, just disappeared, would be helpful with medical appointments? What should I ask?
Right. So this is something, I mean, probably when you all go to your next medical appointment, you're going to get one of those Scooby-Doo reactions. Oh, when they ask them about adaptive communication, because nobody asked for that. But if you've been in the field for as long as I have, you remember this is the same way for people who had other disabilities, like deaf people, for example. The whole entire deaf community, if you look at their history of asking for resources, is very similar to what non-speaking community is doing. So what you can do is you can go and bring your own first. You can go, there's a lot of resources, and some of them are up here, that will provide things about going to medical appointments. But you can ask your doctors. Most hospitals and doctors' offices have some form of a pain management picture, some basic forms of communication. And what you're really looking for is, like the slide I had earlier, do you want something? Do you need something? And if you don't have the particular picture you're looking for, you can do this with whatever's lying around. You show the child before you touch them, or something as simple as having the doctor model it on a doll. And you have that be your doctor doll, and they show what they're going to do. But the idea is that you get consent before you start putting a needle in the kid's arm.
Okay. How do we as parents advocate for our children in a public school setting? I feel as though most IEPs are generic and there's not enough variety and options to teach autistic children. Another excellent question.
That is a big rabbit hole.
Mm-hmm.
And depending on your child's specific needs, there are some excellent parent advocacy groups out there. A good first place to start, which didn't make it on my slide because this is a self-advocacy slide, but for parent resources, is Pathfinders for Autism. Neil Lichter is one of the directors, and he's very available to answer questions about things like that. But in addition to Pathfinders for Autism, some general special education resources through the CCAC, I'll add that to the list, the special education advocacy committees in your county can be very helpful. Parents Place of Maryland is also very helpful. If your child specifically has communication differences or disabilities, Communication First is a great resource. And then I recently became aware of the International Association for Spelling is Communication. And they are a great group that is lobbying to get more and more typing as a support in schools, because a lot of the kids can type who can't talk. So my advice to you is to start with whatever community organizations that are closest to you, either SECAC, Special Education Citizens Advisory Council, or Pathfinders, and then to try to get resources there, connect with other parents. There is the Autism Society of Baltimore Chesapeake has a monthly meeting, and start there. And then if that doesn't work, then go back to Pathfinders or Communication First to get an advocate, because there are pro bono lawyers and advocacy resources, people that even parents have been through it before that can help you with the process. And if all that doesn't work, you could get the Rights Law book, which is From Emotions to Advocacy, which is a lot of helpful tips.
That's great. Thank you. All right, we got quite a number of questions coming in here, so I'm going to try to do fast round here. Is ADHD part of ASD, or are they different?
I have a whole hour talk on that difference.
We don't have an hour.
Diagrams, and it's delightful. So I am an ADHD, anxiety, speech therapy person. So those are my diagnoses. And as a child, feeding therapy included. So I went through a lot of similar things as people with autism, but I am most certainly not autistic. I wouldn't want to misrepresent myself. ADHD has to do with a particular region of the brain, and also some chemical differences. The overlap with autism is that this particular region of the brain, the prefrontal cortex, might have more brain cells. They didn't get prunes off and taken away in the same way that they usually do in development between the ages of 3 and 5. And so you can pay attention to more things. You can hyper-focus for longer periods of time. Those are the strengths. You can also, at your lowest level, be very scattered and disorganized and all over the place. So ADHD is a dysfunction in controlling attention. It's not a deficit in attention. A person with ADHD can go 3 days working on the same thing. And autism can be like that because they share that region of the brain. But there's other regions of the brain that are differently affected, motor regions and facial processing regions. So a person with ADHD does not struggle with reading social information the same way. They have a general difficulty with controlling attention, but they don't miss some of those things. So I guess the simplest version of that is ADHD is about controlling focus. Autism is more about social focus differences and sensory differences. And the overlap, it comes when autism is not treated on time. And so you don't have that structure in regular development to learn to control and manage your attention the same way, because school hasn't been working out for you and you're constantly startled. So those symptoms might develop more than they would in a neurotypical kid. And they interact with each other, which is complicated. But they are different, and they do have different treatments. And if you have an autistic person with ADHD also, the treatment for ADHD is therapy, and there are medication options that are very effective for ADHD. So that child with autism, if autism is if it's a low amount of autism and a high amount of ADHD, they might do very well on ADHD medication. Whereas if you have a child that has a high amount of autism and a low amount of ADHD, they might do better on something like risperidone that is more traditionally associated with the autism symptoms of anxiety.
Dr. Johnston, let's do this. Can we turn to the last 2 slides so I can give our viewers some information, and then we can come back to some of these questions. I don't think we're going to get to all of them today. All right, so several people have asked in the Q&A whether or not this information will be available. The entire webinar will be available in about 48 hours for you. You can see the slides there and rewatch the entire webinar. As well, there at www.letstalk, you can see any of the prior Let's Talk community conversations that have happened. So that's that. The next slide tells you what the topic is for next month, the third Wednesday in the month, which is May 17th. And I've got my Q&A up that I can't see, and that will be on lupus. So some people may want to join us for that. So I wanted to make sure that people had that information. Let's go back to that last slide, the right one, right before this, so they can keep it up and get that information if they need to. I'm going to try to do this round robin really fast. No,
okay, wait, this
no,
one?
that one. Leave that there. So
okay, thank you.
Figure out the website. Thank you so much.
Mm-hmm.
Okay, we're going to try to do a few of these, but we are losing folks. Are the skills and approaches to working with autistic adults similar to that which you've described for children?
Yes, but I'm not. Yes, they are. I am not an expert in working with adults. I have not worked with adults since the 90s.
Understood.
Directly.
Okay. Next question. There's a long delay for speech and related evaluation and therapies for people with autism, sometimes up to 2 years, which is a real problem because of the delay of services that you would get at that age where they would be most effective. Meanwhile, what suggestions do you have for support when some of us are not experts in this area?
That's a tough one, and that is a systemic issue, and there are workarounds. Some families have been seeking virtual options that are available in other places. I know families that have organized together to try to pool resources. It is a problem that we're all facing right now post-pandemic because of the surge in referrals. I'm not sure how to solve that problem, except for to be persistent when you're on a waiting list, to ask if there's other options, and then to also ask the clinics. I know at the Autism Clinic, we did a shorter model where we would do like an abbreviated version of the assessments so that you could just get the information that you needed in order to get the referral to the next step. So for example, applied behavior analysis, home-based, is something that you need a diagnosis of autism, but you don't need a full psychological evaluation for. You can just have like a consult with the developmental background and a standardized assessment test that could be done by parent interview, like a CARS childhood autism rating scale, which means you don't have to necessarily wait. Make sure you're waiting in the right line. You don't necessarily have to wait in the long line to get like the full IQ test, which, as we discussed, isn't so meaningful for you. You may just need this particular diagnosis to get on to the next step. So while you're waiting in line, make sure you're in the right line and make sure that that's the criteria that you need to get to the next step, and always work backwards from what services you need. So a child needs speech therapy. Okay, what diagnosis do they need to get there? And who can get that diagnosis the fastest? And talk to put your name in multiple wait lists.
I have a couple of last questions. At what age, realistically, can a child become their own self-advocate?
As soon as they can make any sort of reliable choice. I'm playing with that. I'm pushing the boundaries there, but I could show you at some point. But literally, you have a kid who's I've worked with kids who have had horrible experiences. I worked with a child who was essentially a feral child who had nothing for 7 years. And in those situations where there were no skills in the beginning, we did what we could with what we had. And yeah, that might be the service bell. The kid's aiming to reach or hit, and you use that service bell and you say, yes, can I get you something? And it's literally the simplest motion of pushing your hand down. And I've worked with kids who were estimated to be severely intellectually disabled, and their choice to start or stop could be as simple as a tap. It could be just the basics. But once you give that dignity, it invites them to participate in a meaningful way, and you'd be surprised how much the motivation goes up. And then therapists get to keep their gummy bears because you're creating a relationship.
Similarly, suggestions on the best methods to try to teach a child at age 3 that's not very interactive.
So the kid is paying attention to something. Whatever they're paying attention to. And also it's very important, interactive, we're using our glasses as neurotypical people to estimate their interests. And there's a great book called Strategies for Improv. It's about improv with kids with autism. And it goes across from high functioning, low functioning, support needs levels. And it can take kids 6 months before they start to respond and show their emotion about something that they're interested in. So just because it's not immediately recognizable that they're interested doesn't mean that they're not interested. So you sort of test the waters and keep trying it out and see what it is that they're paying attention to. And maybe they're paying attention to just strings. They're just playing with strings. Great. So what can we do with strings? We're going to have a spaghetti game. We're going to have balls and strings, and we're going to play songs about spaghetti. I did an Easter egg hunt with a kid, and every single Easter egg inside of it was a ribbon of a different color because the kid only really liked ribbons at the time. So she was thrilled because that was meaningful to her. So we really try to look at what they're doing first and join them, and then try to build on that so that they can develop it.
Just so you know, your talk about autism and ADHD resonated. A parent wrote in that they have a child who has both. And then the last question here, I believe we got through them, yes, is, and I don't know if you'll know this, my daughter is 18, just diagnosed with autism and ADHD, a second one. I'm trying to find resources for her in Laurel. I don't know whether any of the resources you shared were in that region, down in Prince George's County, or if anyone still on the line has resources that you'd like to put in the Q&A for Prince George's.
So, yeah, I would love to get resources. We have a therapist at our hospital who specializes in transition youth, which is kids who are transitioning from high school to the next step. And that's very important. That is not my specialty. I work with the younger kids. But there's a great program in Towson University. They have a lot of supports. And a couple of the resources that I posted, one of them specifically from OAR, has great online resources for teens on the spectrum, and it includes a lot of visual prompts. So it covers the kids who can speak actively and the kids who still need more supports. And there's a lot of self-advocacy groups that will help. My number one advice is to find a group of other autistic self-advocates so that she can work on her identity and sort of unpack the things that might be upsetting her, because anyone that has been criticized for things that they can't control their whole life and are late to the party with the diagnosis will have rejection sensitivity. And over the years, just with ADHD, a child with ADHD by the time they're 12 gets criticized 20,000 times more than a kid without it, which builds up to depression and anxiety when they're a teenager, and a lot of that risk-taking behavior or self-sabotage and insecurity. So before she gets there, naming it and having her sit in a room or virtually with other people who have experienced that will help her develop a more positive narrative about her life and make the decisions going forward.
Great. Thank you. Dr. Johnston, thank you for such an informative discussion. Certainly appreciate it. I know I speak on behalf of everyone who tuned in. And just as a last reminder for our viewers, you can see this recording and the slides again in about 48 hours at www.ums.org. let's talk, as well as all the other topics that you see listed there. Thank you again, and everyone have a great afternoon.
Thank you. Thank you so much. I really appreciated the opportunity to talk about this, and I could spend the rest of the day talking about it. So thank
Very
you.
much appreciated.